the oxygen percentage of used generally when you're making a CPAP treatment?
Can I answer right now?
Yeah.
Yes. It depends on the machine. If we have machine, we titrate oxygen concentration to arterial saturation. So this is the way we do. These patients are not sedated, most of them. They are breathing, they try to breathe, and we adapt the concentration of oxygen, the flow of oxygen, because if you have a respirator or ventilator, you can adapt the concentration because it's monitored in the machine. But if we have a CPAP system like the Bussignac system, we just monitor the flow and we adapt the flow of the system, which means when you increase the flow, you increase the pressure, and we adapt the flow to SpO2. Our objective initially was to maintain SpO2 above 90%, and finally we decided maintaining SpO2 above 85 and not pushing too much oxygen into the patient. We try to limit patients who are needing oxygen, but sometimes too much oxygen may be deleterious for the patient. So we titrate to obtain 85 to 90% oxygen. And each time we reach this objective, we try to lower the flow of oxygen in order to test the patient and to know where is it in the stage of illness.
Okay. Okay. One of our question, I think what is also really important with CPAP is, as you said when we prepare the meeting, is that when you use CPAP and non-invasive ventilation, what you want to do is to avoid tracheotomy or to avoid intubation. You try to avoid intubation because it could be worse for the patient. It could be maybe 15 days, 15 days more of 15 days of treatment.
Yes, what we observe that when you decide to intubate a patient, because some of my colleagues were intubated very early initially, and finally learning from Italy and China probably, we decided try not to intubate too quickly. And we proposed the patient to give the patient pressure and oxygen before tracheal intubation, because when you are tracheal intubated, usually you worsen your lung. But mechanical ventilation, positive pressure ventilation alters the lung, creates inflammation of the lung. It has been demonstrated 25 years ago. Too much oxygen alters the lung. So when we decide to anesthetize the patient, paralyze the patient, intubate the patient, put it in prone position, we are increasing, we are majoring the inflammation of the lung. And probably, although we treat the patient, it gives us the time to treat the patient, to give antibiotics, to give different type of medication to the patient, anticoagulation. But we need, after this time, we have 1 week, up to 10 days mechanical ventilation. And then we have to win. And during this time of mechanical ventilation, the patients are sedated, no more, and they lose muscles. And it's very difficult to recover this muscle later on. So we have to try to customize them most of the time after 15 days. And then we have to win the patient. So decision to intubate the patient means that you will have 10 to 15 days mechanical ventilation later. And this is a risky situation. Mortality in ICU when you are intubated is between 30 and 40%. We decided not intubating our patient, give them oxygen and pressure. And finally, we succeed in this strategy. We prevent, I'm sure we prevent tracheal intubation, and we prevent dangerous tracheal intubation in some patients. Sometimes our patient needed tracheal intubation because they were agonic. So we decided they were tired. They were not anymore able to breathe. So we intubated them and we ventilate with the mechanical ventilation. But we try to make non-invasive ventilation as long as it was possible. And in our system, we had a system where we were able to detect this patient that will require oxygen. When they were requiring oxygen, we monitor them and give them pressure. And finally, most of them, I would say most of them, were weaned from oxygen and left the hospital without being intubated.
Thank you very much. We find Pascal. Pascal is back, and maybe he could actually. Tom did your presentation.
Yes.
Any comments, Pascal? Yeah.
But it could be awesome to have your comment. Yeah.
Yes, because my comment just to told people that question. My comment is question. Some questions.
Let's go with the question.
Is it possible now, because I know that you did my presentation, just to ask if it's possible, because in Africa we have oxygen problem with ventilator, with CPAP, we need oxygen. Is it possible to take care to coronavirus people with concentrator? Is it possible? Because in Benin, we don't have serious cases. You see in the presentation, we don't have serious cases. Our people, they are young. They are young people. We don't have like at Europe, like diabetes, old people. Then is it possible for us? Because with ventilator, you need to intubate patients. But how about concentrator? That is the first question. The second question, is it possible?
Pascal, let's hold that question. Second question, Adriana, do you want to respond, or Gilles, about the oxygen concentrator use? Either of you?
Maybe Abderrahim can respond to this question.
With the last device that presents Gilles on his presentation, the CPAP Boussiniac, you can make it work without oxygen, just a mixture of air. If you have compressor, I think in Africa, air compressor are available. Although the oxygen is not a resource, is a rare resource. With compressor, you can make it because the CPAP of Boussiniac operates to achieve two main objectives. The first one is to provide assistance to the patient's respiratory work, whether in the inspiratory and expiratory phase. And for that, she just needs to have a high flow gas supply, whether either if it's not oxygen. And you can, with the concentrator, increase the fraction of inspired oxygen by another access to the device. And you can, if you don't give a lot of oxygen to the patient, you will help him in the respiratory work. And this is the first indication for the COVID patients.
Thank you.
I don't know if I was clear.
It's clear.
Okay.
Thank you very much, Farid. May I just add a little bit more of the answer of Farid? What is also really important is to put filter on your air compression machine, because you're gonna improve the pressure on the lung of the patient. And if the gas is not so clean, you can have also other problem. But it could be used only with air. That's right.
Yes.
Next question, Pascal.
Next question. Pascal, please. Yeah.
Pascal, you said that you have two questions.
No, I have question for Farid now.
Okay.
That compressor you talk about.
Yes.
Can the compressor give the patient oxygen or medical air?
It's it can work with ambient air.
Only ambient air. It's just
only
air.
ambient air. You just have to have the right pressure to operate.
Okay, thank you.
The air compressor is available for that. and you just supply with oxygen, because I joined the vicious circle that Jill was talking about before. The improvement of the respiratory work, as I said, contributes to a better oxygenation of the tissues with, by a higher intake of oxygen from the ambient air. And the oxygenation of the tissues decrease the need of respiratory work. So the two elements are joined, and they stop the vicious circle that Jill was talking about before. Okay.
Yeah. Adriana, yes, tell us.
Yes, thank you. I just wanted, Pascal, for you and many of our colleagues from Sub-Saharan Africa, WHO is now procuring oxygen concentrators, but also PSA plants, and we're even thinking of our liquid oxygen to support all hospitals, COVID hospitals, so that they can stay, they can get the oxygen, and that oxygen can stay forever, no? Because we know and we are very aware of the lack of oxygen for surgery and for many other things. So that was the talk on Monday, but still it is in the catalog and we're procuring it as WHO. So, and then what we want to do is a match table between which ventilators or CPAP or whatever can be run with an oxygen concentrators and which cannot. And then, as Farid was saying, some run with compressors, others not. So we would like to do something like that to have a comparison table. We don't have it now, but maybe that's something, Tom, that we can put into the things to do. Over. I think there are many questions about if we use non-invasive or invasive ventilation. I think this is a clinical decision, but in reality, depending on the patient you have, and there were various questions saying only use one or only use the other. I don't think there is, so Gilles, you can respond to that, but it really depends on the patient, as you saw the clinical flow. And in WHO, please note that the clinical management is going to be updated in the next week. So as soon as we have it, we can send it to all of you. But right now we are considering both. Originally it was only invasive ventilation, and now we're considering both of them. That's why we put them as technical specifications, and WHO is procuring now CPAP, BiPAPs, and nasal cannulas. Over. So that was just to respond to some of the questions, Joel, but I don't know if you want other questions to be answered.
Thank you, Adriana. I would just talk about another question that I saw, maybe talking about the ionization of the virus when you use non-invasive ventilation. As Gilles told us, it's really important to avoid the leak of the mask and try to have a mask. The sealing of the mask is really important. Maybe there is also a needed to add a filter. Maybe you could told us, Mr. Donor.
Yes, maybe I can tell about that. You're on mute, Jill. You're muting.
Yeah, that's it.
Can you hear me?
Yes. Yeah, that's perfect.
Yes, I could hear your question. I could hear your question. What we try many CPAP system, because we are talking about mechanical ventilation, which is sometimes invasive or not invasive, and invasive or not invasive depend on the device you put in the mouth of the patient. If you put a mask on the face, it's non-invasive. If you put a tracheal tube, it's invasive. So I think that during this pandemic, we try not to intubate, so not to make invasive ventilation, but rather to make non-invasive ventilation and to maintain non-invasive ventilation until the patient was weaned from this ventilation and will leave the hospital, or sometimes we need to intubate the patient. What I would say that if you have a ventilator, you can make non-invasive ventilation via a face mask and you benefit from the filter of the ventilator. But if the pressure, if the patient is coughing, if the pressure of the mask increase too much, there will be leak, and this leak will contain aerosolized viral particle. When you use the CPAP, different device of CPAP, the Boussignac has had this particularity, always the Boussignac. I am sorry to tell you that Dr. Boussignac is sick right now. He has been infected by the virus, and I'm not sure he will survive. No, it's true. And it's so good. I know him, and I received a letter from his family telling me that he was hospitalized and was in poor state. However, I would say his system is very clever. It's open, which means you can breathe and you can speak through it, and you can put a filter and then put the CPAP on the top of it, which means that you will be able to breathe safely and expire outside safely. There will, with this CPAP, which is not a ventilatory system, you can breathe spontaneously. It's open. You can put a pen in it. It's open. You can put a filter and the CPAP on the top of it, and you prevent any aerosolization. Since there's no pressure, there's a pressure defined by the CPAP, that there's no overpressure, always open. So we compare different systems, and clearly the system working with the filter are very important in this pandemic in order to prevent contamination on the environment of the patient and preventing also contamination of the caregivers. This is very important for us. And this is the reason in this hospital, we have all the system allowing to promote non-invasive ventilation. We select the Boussignac CPAP. Was I clear?
Yeah, sure. Maybe Adriana could add some stuff.
You're mute, Adriana.
You're mute.
You're mute.
You're mute. We can hear you, Adriana. We
Sorry.
can hear you.
No, I was just looking into the question from Ehsan Bukola, which I think it is very important and links to all this one. What Ehsan is saying that maybe less than 5% of patients require ventilators, but they are not still enough. So I think it is something that the clinical doctors have to make a decision in the time, exactly following what Jill was saying. So when the patients arrive, they said, okay, which ones go for non-invasive ventilation and can benefit from that? And the ones that are really critical, that you have no other option, then you go to the invasive ventilation. But in reality, yes, Ehsan, you're totally correct. It